The webinar will begin shortly. Please remain on the line. The broadcast is now starting. All attendees are in listen-only mode.
Hello, everybody. This is Phil Wilchis, one of the health educators for the Department of Health. I am currently trying to unmute everybody part of VAC, so please be patient, and hopefully I'll let Michelle get started here in a bit.
Well, good morning, everybody. We'll give it just a couple minutes, as Phil said. He's getting all the VAC members in. Everybody's VAC members are going to be able to have their cameras on and turn their own microphones on and off. So just please make sure you turn your microphone off when you're not speaking. But we're really glad to see everybody. Thanks to show you. I appreciate everybody showing their faces.
Hello?
Hello, we're just waiting for a second to get started. We're getting all the VAC members into their meeting.
Okay, thank you.
Okay, and Phil, I think you probably see Kathy's just texted me, Dr. Lofi. She's on, but waiting to get pulled into. Great, we're just gonna give it a couple more moments till Phil lets us know he's moving all the VAC members to panelists, so everybody will be able to turn their own microphone on and off and their own camera on and off. And we just ask when you're not speaking to please make sure you mute your camera, you mute your microphone.
All right, Michelle, I think VAC members are on, and if you're a DOH employee, you're next.
Great. Perfect. Well, Dr. Lofi, I think we're ready to get going.
Great. Well, it's wonderful to see everyone. Thank you for all putting your cameras on. I wish we were in person, but of course, this is the best we can do during our pandemic. But welcome. My name is Kathy Lofi. As a reminder, I'm the State Health Officer, and I chair the Vaccine Advisory Committee, and I help to facilitate this meeting with Michelle Roberts. Just a few, before we get started, we do have a fairly ambitious agenda today talking about the COVID-19 potential vaccine candidates that are being studied. But before we get going, I just want to handle a few housekeeping items. This is a shorter meeting than usual. It's 2 hours long. This is a public meeting, so there are additional people on the line that are in listen-only mode. and they are all muted. So just so that people are aware, the back members can see each other and can talk, but other folks are on the line as well. It's great to see everybody's face. Please keep your cameras on if you feel comfortable with that. The other thing I want to draw your attention to is that since this is a shortened meeting, we don't have verbal public comments, but we did send out a number of written comments that have been submitted to the committee. They were in the packet of materials that Hannah sent out to you. I believe it was within the last week. So I hope that you all had a chance to look at those comments. And I'm going to talk about them just briefly. The other thing that was in your packets, there are all the slides from today were handed out along with our conflict of interest form and some bios for some new members. So if you can pull up that email, that might be helpful to have in front of you. And those materials are on our website as well. So before we have the VAC members introduce themselves, I do want to introduce a few new VAC members. And I'm not sure if all of them were able to join us today, but I do see Anita. Hi, Anita, and welcome to the committee. Anita is a public health nurse consultant in the Child Care Health Program at Public Health Seattle and King County, and she's representing child care. So really happy to have you with us, Anita. When we go around and do introductions here, we welcome you to say a few more words about yourself if you feel comfortable doing so. Another new member, and I don't know, I'm not seeing her on the phone, is Annie Hetzel. Is Annie here? Okay, maybe she's still being pulled into the meeting. She is our new representative from OSPI. She is the school health services consultant with the Office of the Superintendent of Public Instruction, and will be representing OSPI on this group. So hopefully she will be joining us shortly. And then the third new member is Wendy Stevens, who is a new representative from the American Indian Health Commission. And we hope that Wendy will be able to join us as well today. But next, I want to just go along. I'm just going to go across the pictures in the order I see them, and I'll quickly call your name. And if you could just introduce yourself, that would be great. We'll make sure all the technology is working. So Michelle?
Yeah, good morning, everybody. I'm Michelle Roberts. I'm the Acting Assistant Secretary for Prevention and Community Health, and help Kathy with facilitating of this group. So glad to be with you today. Kathy, I also just wanted to say Sarah Murray, we introduced her last time, but it's her first meeting she's joining us. I know you'll catch her, but she is one of our new members from the Washington Association of State and Local Public Health Officials, and she's a communicable disease nurse from Walla Walla County.
Great, Jeff?
Hey, good morning, everyone. Jeff Dukin. I'm the health officer at Public Health Seattle and professor in adult infectious diseases at the University of Washington. And I've been on the advisory committee for immunization practices for a long time, over a dozen years, previously as a voting member and currently as a member of the COVID-19 vaccine work group.
Great, welcome. Anita?
Hi, everyone. This is my first meeting, but it's nice to see you all. I'm a public health nurse with Public Health Seattle and King County, the new child care representative on the committee, and just really excited to meet everyone and work with you all going forward.
Great. Beth?
Hi, everyone. I'm Beth Harvey. I'm a pediatrician in Olympia at Southtown Pediatrics, and also a member of the Washington Vaccine Association and on the committee as a consultant.
Usha?
Hi everyone, my name is Usha Rao. I'm a family doctor at the University of Seattle, and I represent the Washington family.
Great, Greg?
Hi, Greg Endler, Department of Health, Deputy Director of Health Promotion and Education within the Center for Public Affairs.
Jean?
Hi, I'm Jean Gowan. I'm one of the clinical program managers at the Healthcare Authority, and I manage the vaccine program.
Rachel?
Hello, Rachel Wood, Health Officer in Lewis County.
Tristan? Oops, I think you're on mute, Tristan. Oh, you're still on mute. Do we know if she's unmuted from our end? Okay. Well, maybe we
is unmuted on our end.
Okay. Well, Tristan Lamb is the administrator at the Kittitas County Health Department. How about Sarah?
I'm Sarah Murray. I'm a public health nurse in Walla Walla County.
Great. Amy? Amy Poole?
Hi, my name.
I represent the Urban Indian Health Programs in Washington State. So Seattle Indian Health Board, the Native Project, and then also the Portland Urban Indian Program that also covers Clark County.
Great. Stephen Pearson?
Yes, I'm pediatrician in Yakima, Washington, and both representatives of Washington Chapter DAP.
Great. John, Dunn?
I'm muted, that's what I am. I'm John Dunn. I'm the Medical Director for Preventive Care at Kaiser Permanente, Washington, and I represent managed care on the committee.
Pam? Oh, I think you're on mute. We're still not hearing you. I'm still not hearing her. Is anyone else?
Yeah, I'm not either. And so for members, maybe some of our moderators can help see if they can solve the problem for you. And please feel free to use that chat box, which is between our DOH staff and the back members too.
Susan?
How about now?
We can hear you.
I'm a family physician in Wenatchee, representing Washington Academy of Family Physicians.
Great. Jenny?
Hi, I'm Jenny Arnold, a pharmacist and the Director of Pharmacy Enrollment at the Washington State Pharmacy Association.
Sheanne?
Good morning, Stephen Allen, COVID vaccine, Director of Pharmacy.
Okay, and it looks like we also have Amy Person.
Any person has come on my phone, so I can't be health officer for Benton Franklin and county representative.
All right, Amy, you're really soft. We could hear you. We could just barely hear you. How about Dan Mormon?
I'm Dan Morgan. I'm a pediatrician in Washington Community Health, and I represent the Washington chapter of the American Academy of Pediatrics.
Great. Ed Marcuse? Ed, if you're speaking, we cannot hear you. Still can't hear you, Ed.
I will work on it.
Oh, there you go. We got you now.
Okay. Hello. Sorry for the difficulty. Emeritus Professor of Pediatrics at the University of Washington, Consultants Committee, and I've had the privilege of being a part of this committee since its inception.
Great. Nice to have you. Mary Anderson? Mary, if you're talking, we cannot hear you.
And Kathy, I see a note that Mary is saying she cannot unmute. So Mary Anderson, Internal Medicine, Seattle, representing American College of Physicians. And Tam Lutz also introduced herself in the chat box as well. So Tam Lutz, MCH Programs Director at the Northwest Tribal Epicenter. And Rachel Wood, I think you're unmuted and might be accidentally some of the cause of the background noise. We'll double check.
Sorry.
It's okay.
Mary Hoon.
Hi, I'm Mary Lynn. I'm with the Office of Immunization and Child Profile and helping she and Alan with the COVID-19 vaccine response.
Great. Is there anyone from the committee who didn't get an opportunity to introduce themselves? Okay, well, let's go ahead and keep moving because we have a lot to cover. Before we get started, I just wanted to make a comment about some of the public comments we received. I read through them all last night, and there are a lot of comments that expressed a lot of concern about mandating COVID-19 vaccines. And I just wanted to report to you all on the committee and to you know, the folks who may be on the line who submitted some of the comments, is that there have been no conversations at the Department of Health or within the governor's office around mandating this vaccine. It's really not anything that we're thinking about at this particular time. So just wanted to, you know, hopefully reassure some folks that wrote in to the vaccine, to the VAC and submitted comments. Just wanted to address that since it was such a common comment that was submitted to us. Yes.
Mary Conkey, hi. Sorry, I don't know why my video wasn't working and now it is, but I just want to say hello. I'm here.
Okay, welcome.
Introduce myself. I'm Mary Conkey. I'm a naturopathic pediatrician. I've been on the VAC for about 6 years and am involved in the Immunization Action Coalition and the task force for the new COVID vaccine.
Okay, great. And then, oh, anyone else?
Yeah, Kathy, this is Scott. I'm on. For some reason, the organizer has us muted, so you might ask them to go through and unmute people.
Okay. Hopefully the organizer heard that. Okay, great. So my next announcement to you all is I wanted to announce to everyone that I will be leaving the Department of Health towards the end of the year. This was publicly announced yesterday. Some of you may have seen the announcement. This has nothing to, there's really no particular reason besides it's time, you know, for me, it's the right time for me and my family. I just looking forward to taking a little bit of a break, taking some time off, exercising more, which I haven't been able to do very much this year, reconnecting with some friends and family, and you know, focus on being a mom. So that's my plan after the end of the year, to take a little bit of time off and then think about what the next adventure might be for me. So just wanted to make sure that you guys are all aware of that. We are talking about, you know, potentially having another VAC meeting before, you know, the year is over. So hopefully this won't be the last time I will see you all, but just wanted to make sure everybody was aware of the plan.
And I'll jump in here. We sent the link to the formal announcement. I just want to take a moment, and then we were going to open the floor, but I think we all know how hardworking, maybe the hardest working person in Washington State, and how humble Dr. Lofi is, but she has been with the department for 13 years. She started, when I first got to work with her, was as an epidemiologist doing the influenza disease surveillance for the state. And then she went and was the state health officer for 7 years almost. And that role really is kind of as the state's top medical position, state's public health leader, really making sure we've got strong connections to science, helping ensure we've got strong connections to our clinical community, making sure we understand the clinical implications of our work in public health. And like I said, nobody digs into the science more and is an advocate for the science and really what the evidence shows, both positive and negative, than Kathy is. And she's been a huge champion for immunizations, for evidence-based work in immunizations, and across the board at the Department of Health. So it's been really a pleasure to work with Kathy and to just learn and serve alongside of her. So I'm excited for her. I know she's got teenage boys that will be happy to have her more available. And with sports schedules and other things, she will be very missed. And I think you guys probably know that the Secretary of Health is also leaving, Secretary Wiesman. So both of these were decided that, you know, just the timing aligned with the end of Governor Inslee's second term. And so it was the right time for them, and they both have served in really challenging jobs for I think 8 years. So it will be a lot, and I'm really excited for them to have their next chapter. We, as a department, the governor's office is working on hiring the secretary position, so more to come on that, probably not till maybe after the election. And then we're trying as a department to, and John and Kathy are leading us to make sure everything's ready to go for the hiring of the health officer. And so that when the new secretary is here, they can finalize that process. So luckily, Dr. Lindquist is still going to be with us as the communicable disease officer for the agency, and he is an infectious disease pediatrician. And Scott, if we can make sure Scott's off mute, I think he wanted to say a couple of things too. And then we'll put it up.
Yeah, can you hear me, Michelle?
And we can.
Okay, so more to Kathy. I mean, in my career in medicine, Kathy has probably been the best partner in medicine I've ever had. So with that, it's going to be really hard to see her go. I definitely applaud her for looking out for herself and her family, but I can only enforce what Michelle said, the most humble, hardworking person we've got. And it's going to be hard to replace her, as we all understand what that means for the Vaccine Advisory Committee, what it means for DOH. It's going to be very difficult, but I just want everyone to really just take a minute to thank Kathy for all she's done for Vaccine Advisory Committee and for the state as a whole. So Kathy, more to come on this, but I met you when you were an EIS officer and you came out to Kitsap to drag for ticks. You've come a long way. And I really am gonna miss you.
Well, thank you, Scott. That is very sweet. And it's been a pleasure to work with everybody. It's been a hard year, but it's been really amazing how everybody's kind of come together, you know, really to get through this pandemic. And I do not work harder than Jeff Duchin. He is definitely the hardest working public health official in the state. All right, well, let's go ahead and
Kathy, before you go, I didn't want to open the floor. We told members we'd open the floor in case anybody else wanted to say anything. So you get to shine in the glory for a moment of admiration. But if anybody else has anything they want to say.
This is Rachel. And Kathy, you're such a can-do kind of person. And I can't say enough in gratitude for all that you've done and how you've remained a star despite some tough times. Well, thank you.
This is Chaz DeBolt, and Kathy, I just want to say that I also remember you from when you were an EIS officer. And you and I was at Public Health Seattle King County as an investigator, and we were working on SARS. So it's a little ironic that you are leaving in SARS-CoV-2. It's been a pleasure.
I remember that well. You know, back in SARS-1, I was the only person, I think, in the department that was really working on it. So it's been quite a different experience this time around.
I think you were too, because you were my only contact at DOH.
this is Mary Conkey. I just wanted to comment that in the 6 years I've been on the VAC, I have really admired how calmly and maturely you handle contentious situations, and particularly when there's been, you know, public comment and a bit of back and forth that was a bit contentious. I thought, wow, Kathy really holds it together so well and addresses things in such a mature way. And I just thought, wow, I would like to hone more of that in myself. So it's definitely been inspirational just watching you sort of lead the group through all the changes past years.
Well, thanks, everybody.
Hey, no.
It's really fun.
I mean, I'm so appreciative for all the feedback that you've had from Michelle and others. I agree with everything, and I want everyone to know that as a health officer, Kathy has other responsibilities outside of the VAC, many. And she's also the leader of Washington State's health officers. And as myself being the health officer for the largest county, we've had so much opportunity to work with Kathy over the years, and have the exuberant appreciation that you've all expressed in how you got to know her through the VAC. In our other areas in which we work with Kathy, you've just been such a tremendous partner, and I know I've had more opportunity than most to badger you and to work with you, and just appreciate your tremendous collaboration and leadership. And I'm going to miss you a lot, and I'm envious of what you're doing, and I'm happy for you.
Well, thanks, Jeff.
Kathy, you've been such a neat partner to work with, and how collaborative and open you are. And I know I've been on the phone with you at 11 o'clock at night trying to solve the measles outbreak and getting IGIM where it needs to go. And you don't hesitate to just pick up the phone and solve the problem across lines and just dig in yourself. So I'm just going to miss that collaboration, and just have appreciated just your open, positive, can-do, dive in and help sort of way of solving problems. So thank you.
Great. Well, you guys are all very sweet. Very nice of you to do that. Okay, well, let's go ahead and move on. We have a lot to cover. And I guess I'll pass it over next to Hannah to talk about the conflict of interest exploration. Is Hannah on the phone?
I'm here, Michelle. Can you hear me?
We can hear you. Yes, we can.
Perfect. Before I jump into the conflict of interest policy, I've been working behind the scenes with our meeting organizer, and I just want to thank everybody for bearing with us on some of those audio issues. I know with this pandemic, there's been a need for these technology solutions and also some technical difficulties. So thank you for bearing with us. I know Phil is working behind the scenes to make sure the folks on back are unmuted, and I'm sure he is double checking that as we speak. And just to remind folks, if you are on your computer, the unmute button is up in the right-hand side. You should have a panel open there. There should be a red arrow to toggle the panel in and out. Underneath that is a little button that looks like a microphone, and if it's on, like mine is right now, it should be green. And so if you're not seeing that, please let us know in the chat, and we can work behind the scenes with you. Perfect. So I'm going to jump into the policy and keep us moving right along. In order for the Department of Health to pursue its mission and to maintain its reputation with the public and with healthcare providers, it's important that the decisions and actions of the Washington State Vaccine Advisory Committee not be unduly influenced by the special interests of individual members. Accordingly, VAC has adopted the following conflict of interest policy. Decisions made by committee members should always be based solely on the best interests of the Department of Health and the people of Washington State. Decisions should not be influenced by personal financial interest or by other extraneous considerations. Any affiliation with an organization having fundamental goals that conflict with the Department of Health and the VAC mission should be avoided. Any current, previous, within 2 years, or future potential conflict of interest should be disclosed at the beginning of each VAC meeting. A potential conflict of interest exists when a committee member has a relationship or engages in any activity or has any personal financial interest which might impair his independence or judgment, or inappropriately influence his or her decisions or actions concerning us, and should be disclosed if the committee member has a relationship with an entity that benefits financially from the sale of vaccines, such as a consultancy, serving on a speakers bureau, receiving honoraria, research, and or travel support, owns a material financial interest in any business that provides or seeks to provide goods or services to the Department of Health, serves as an officer or participates on the board or committees of other related professional societies that receive direct financial benefit from the sale of vaccines, has an affiliation with an organization that has a financial interest in VAC recommendations, has an affiliation with an organization that has a competing activity. Each committee member has a high duty and obligation to disclose to the entire committee any potential conflict of interest and to abstain from any decision where a significant conflict of interest exists. Ultimately, it is the responsibility of the entire committee to determine what, if any, limitations on activities with regard to the committee members' conflict are required to protect the VAC.
Great. Does anyone have any conflicts of interest to declare?
No.
None.
Great. Thank you. And for some reason, if you cannot speak and have a conflict of interest, please put that in the chat. Okay, so let's go ahead and move on. The next item on the agenda is to approve the minutes from last meeting. The draft July meeting were included in the email with all of the materials for the meeting. I hope you've had a few minutes to look over them, and we'll just take another minute for people to look at them if they haven't. If somebody feels ready, please put forth a motion to approve the minutes.
So moved.
Anyone like to second?
Second.
Second the motion. Okay, all in favor of approving the minutes, say aye.
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 Anyone who is not, say nay. Okay, we will consider the minutes approved. Okay, great. Well, we are running on time, so let's go ahead and dig into the meat of our meeting, which is the COVID-19 vaccine response. And with that, I'm going to turn it over to Sheann, who is leading our COVID-19 vaccine response.
Wonderful, thank you. And Kat, you are truly amazing and will be missed. So with that, I'm excited to be here today with you. I look forward to a hearty discussion about allocation and prioritization of the COVID-19 vaccine in our state. I know we have a large group listening in today, so welcome, and we'll get started. Again, Sheann Allen from the Department of Health. So today, we aim to share COVID-19 vaccine planning updates, research COVID-19 vaccine communication campaign, discuss the Vaccine Scientific Advisory Work Group, explaining the scenarios we have been thinking through regarding prioritization and allocation guidance development, and then wrap up with discussing the COVID-19 vaccine engagement plan.
Sheann, it's a bit hard to hear you. It's a little bit like it's hard to get.
Is everybody muted?
I hear the train again.
Yeah, you're coming in and out a little bit, Sheann, so I don't know if you can get closer, or I think if you're on your phone, yeah.
Okay, is this better?
Yes.
Okay, great. Next slide, please. So the illustration on this slide shows the large initiative areas that we've identified as it relates to the COVID vaccine. They include system readiness, data and program monitoring, allocation and prioritization, distribution and logistics, provider networks, vaccine administration and clinical guidance, legal and policy, engagement, and communication and education. Since the start of the vaccine response, the team's goal has been really to be transparent throughout the entire process, communicate often, and really to invest in our partnerships and relationships across the state, because we know the department cannot have a successful vaccine response without all of us working together. Next slide, please. So we are now more than 8 months into the COVID-19 pandemic, with over 1 million COVID-19 deaths worldwide, according to the Johns Hopkins tracker. The United States makes up about 4% of the world's population, yet accounts for over 20% of the confirmed coronavirus deaths. This is a coronavirus tracker. The source is down below. It's the New York Times, and it really provides a snapshot of where we're at. Like this one is as of Tuesday with the clinical trials. The website provides a nice overview of each vaccine candidate, populations the vaccine is being administered, which stage of trials the vaccine is in, and so on. So currently there are about 44 vaccines in clinical trials on humans, and over 92 preclinical vaccines are under active investigation in animals. Next slide, please. So this graphic shows vaccines in the later stage development. It's organized by platform or technology, the phase that it's in, and then also the government support. There's lots of partnering reflected in vaccine development, particularly in phase 3 and some in the early phases. There's been collaboration between industry, Department of Defense, BARDA, to invest in these platforms, which is helpful because it really reduces or shrinks the time it takes to develop a new product that then can start to be tested, which makes it faster to get the vaccine candidate to the clinical trials. Next slide, please. So we know the administration of vaccine will require a phased approach. This is an illustration of the phases of vaccine supply. So the startup phase or the ramp-up phase, which is circled, is where we know there will be a short period of limited doses, and vaccine prioritization and allocation guidance will really be critical. In this period of limited doses, vaccine administration will be highly targeted and delivered to specific sites to administer to targeted groups that have been prioritized for that first phase of vaccine. And then additional or larger numbers of doses will be available later in 2021 for broader distribution to critical populations. We also know that enrollment of a broad network of vaccination sites will be needed, such as pharmacies, doctor's office, public health clinics, pop-up or mobile clinics, and federally qualified health centers, just to name a few. Next slide, please. So the allocation guidance is still in the process of being finalized by our federal partners. The initial phase is expected to include healthcare personnel and other essential workers. So at the department and along with our partners, we've been preparing for several scenarios with multiple variations of like the number of doses that were allocated, which presentations we are allocated, and then just thinking through the different vaccine logistics, such as storage and handling for each of the vaccines. And so we've been preparing for vaccine candidate A, which has some limitations with the storage and handling, the -70 to -80 degree storage requirements, and then also developing scenarios around vaccine candidate B, which is a frozen vaccine. Ideally, we receive a combination of both of these vaccines so that we can have the most successful vaccine response possible for phase 1. Next slide, please. So as COVID-19 vaccine development continues, many are concerned about the safety and the best way to distribute the vaccine once it's available. A recent survey found that a growing number of Americans are hesitant to try an early vaccine, and that the willingness to take a vaccine varies based on who is saying it's safe, the cost, and where it's offered. So those are all 3 areas that we are keeping in mind as we continue our conversations with others. So recently, Department of Health released a statement stating that Department of Health is committed to the science and the need to critically evaluate these new vaccines for their safety and efficacy in an unbiased way before their use. We'll be watching the FDA approval process closely to make sure it's thorough and transparent. So we know safety is always a topic of concern for all vaccines, and it's really important. Safety is really important to the department. And safety is a priority during all phases of vaccine development, approval, and use. Before vaccines are approved for public use, vaccines undergo a robust
review by scientists and independent experts to really ensure the safety, the efficacy, and the continued monitoring. So just like other vaccines, the COVID-19 vaccine will have an independent review by the Data Safety Monitoring Board, also an application review by the FDA, as well as the Vaccine and Related Biological Products Advisory Committee, and must demonstrate that they are safe and that they work. In order to be approved, there must be plans in place for monitoring of adverse events. And then, of course, the Advisory Committee on Immunization Practice will perform a review of evidence and provide recommendations for use. And then, of course, there's safety monitoring that continues post-licensure. Next slide, please. So quickly, I just want to go over some of the complexities and then also some of the assumptions that we have about the vaccine. First, I mentioned the presentations that we're expecting to receive first have differing dose series. One requires 1 dose, the other requires 2 doses. And then as we see more vaccines coming down the pipeline or approved, we are knowing that products or the vaccine are not interchangeable. So that just causes some logistical complications or challenges that we'll work through and think about how we can remove barriers. Next is vaccine efficacy and adverse event profile in different populations. We're seeing this through some of the studies, and so our vaccine scientific advisory work group will really be tracking and understanding what is taking place within the trial so that they can share that information with the department and with our partners. And then, of course, the varying cold chain requirements I mentioned, we're planning for 3 different vaccine cold chain parameters, including refrigerated, frozen, and ultra cold vaccines. Of course, we'll still need to be socially distanced during the vaccination clinic or practices. And then we know that communication and education for our providers, partners, and the public is a must. And then also some high-risk groups for COVID-19 may discuss the public health system. And so working through how we can build those relationships and gain that trust. Next slide, please. Other complications include just the minimum order size of the vaccines. We know that one vaccine, the frozen, the minimum ordering is 100 doses, while the ultra cold vaccine may be larger, like around 1,000 doses minimum order. So just thinking about those logistics as well for storage and handling. Also, the vaccine and the supplies have been procured or will be procured and distributed by the federal government at no cost to those enrolled in the program. The federal government is also going to supply the administration kits with needles, syringes, alcohol prep pads, fact sheets, the vaccine record cards, and then a limited supply of face shields and masks. We know that bandages, gloves, and sharp containers will not be included in that supply, the administration kit. And then some vaccines may require reconstitution, and so the federal government will supply those mixing kits, which will include the needles, the syringes, alcohol prep pads, with the vaccine when it arrives for the required mixing at the site. Next slide, please. So all vaccine providers must enroll by signing the agreement and agreeing to the conditions outlined in the COVID-19 vaccination provider agreement that was provided by the CDC. States will be required to collect and submit information on provider sites, which include the type of site, the patient served, cold chain capacity, and then logistical information for receiving the vaccine. So for example, if the clinic is closed every day from 12 to 1, knowing those kind of things so that we can reduce wastage for delivery. Also, providers will be required to submit the administration data within 24 hours of the vaccine being administered. And then in turn, the state will be required to report to the CDC every 24 hours. Also, all vaccination sites will be required to report to Vaccine Finder. And then also, clinically important adverse events following any vaccination should be reported to the Vaccine Adverse Event Reporting System. And this program will provide, or our program will provide training to all providers enrolled in the program on how to report to the adverse event system or VAERS system. Next slide, please. All right, so distribution will happen in two forms. One, through state management. And so we're lucky in our state that we have a well-established childhood vaccine program that we will be using a lot of the same infrastructure and procedures that are already in place. So the state will receive the allocation from our federal partners, and then as providers order the vaccine, the program will approve the orders if that provider site is approved for the phase that we're in. And then the orders are shipped directly to the provider from the depot or from the manufacturer, just depending on what vaccine they will be receiving. And so we know that we need many access points through this response. And so the program is working with traditional and non-traditional vaccination partners, such as long-term care facilities, pharmacies, and many others. And then the federal government will manage and distribute to select pharmacy chains, national long-term care companies, healthcare systems that overlap multiple states, Indian Health Services, Department of Defense, the Bureau of Prisons, Department of Homeland Security, Veterans Affairs, and I think there's still discussion on if others would be added to this list. Next slide, please. Thank you. So we're waiting for the ACIP recommendations to identify the specific groups that we recommended to receive the vaccine once it's safe and effective. And so at one of the recent meetings, they did share the 4 priority areas for phase 1, and those include high-risk medical conditions, those over the age of 65, healthcare personnel, and essential workers. So these 4 priority groups make up over half the population. So there's a definite need for subgrouping for phase 1 and 2 until there's ample supply of the vaccine. And so in a few minutes, Blair and Katie will walk through with the group some of those ideas that we've been brainstorming with partners. Next slide, please. So right now, the program is working hard to build out the provider enrollment system and develop a toolkit for provider enrollment. The goal is to open up provider enrollment in early November. In the meantime, providers can prepare by reviewing the enrollment content, which is posted on the website for the provider agreement and for the provider profile. Next slide, please. So in addition, healthcare providers can review or develop operational plans for vaccinating staff and patients, and some tools are listed below, or access staffing capacity, or assess staffing capacity for planning clinics and developing a process for training staff that will be involved. This also includes working with occupational health partners to determine their capacity to vaccinate, to hold vaccination clinics, and also identify potential barriers for participation. And then assess the process for monitoring and tracking staff and patients receiving vaccines. And then how the reminder system will be put in place for those patients for their second dose. Next slide, please. In addition, healthcare partners can be identifying refrigerators and freezers to store vaccines, really assessing the capacity and the process for storing and monitoring. They can test vaccination plans by holding tabletop exercises or reviewing their seasonal influenza vaccination clinic information. And then also to determine capacity to serve as a site for vaccine storage for the community vaccinators. Next slide, please. All right, so at this time, I'm going to pass it over to Greg Endler to discuss the COVID-19 vaccination communication campaign.
You know, before we go into this next section, I just want to ask, first of all, does anybody have any questions for Shian? Because that was a lot of information. And I know this is like the first time a lot of you guys are maybe hearing this. So are there any questions? Mary Allison?
Yeah, can you repeat where different providers can access to start preparing the reviewing enrollment information and sort of start preparing themselves?
Yes, I will put it in the chat box.
Oh, great. Okay, thanks.
So do we have a website, Shian, for providers that has all the information for them on it?
We do. It's on the COVID-19, and then it's backslash healthcare providers, and then that's where we're starting to build out. Also, we're building out a vaccine website, and so there is there on our engagement process, and then also our general public surveys posted on there. There's 2 places. I'll put both of them in the website or in the chat.
Great. Sam? Oh, do you have a chat? Did you put in the chat? Okay, my understanding is that tribes will also have the option of opting to obtain a vaccine directly through states. For what we've heard on the American Indian Health Commission and IHS presentations. Can you address tribes, Shian?
Yep. Our the tribes will have the option, or that they can choose if they want to receive vaccines from the federal government or from their state. And so I think that CDC is in the process of having those conversations with tribes. And I don't know if there's been like a deadline, a date to let the CDC know what method they choose, but I know those conversations are happening, and that is an option that the tribal nations have.
Great,
I
thank
think
you.
that's also going to be an option for the urban programs that aren't tribal specific. So,
okay, great.
I think we're pushing back a little bit actually on the idea that we have to choose between either the state management system or the federal management system. We'd actually like to be able to use both and manage it ourselves. Just
okay,
Thanks, Amy. And I'll say a couple more things about our government to government relationship with tribes. We are waiting for written details from the federal government, and I know there's been some tribal engagement and consultation at the federal level. I think we're both probably waiting to see what the outcome and the guidance is from the federal government on that. And then the department's working towards regrouping with a tribal roundtable later this month. That more information is going to be coming. So Amy, it'd be great to make sure, and you can follow up with me afterwards, but to make sure that gets on the table at the roundtable, where we're really going to keep digging in our government relationship with tribal nations. So, and the urban Indian health centers.
Tim, did you have another question? Let's see. And will states require estimates of population and the highest risk population figures? Or is the state asking tribes for estimates of population and highest risk population figures? And how do they provide that and when to help determine priority populations?
Those great questions. The conversations will take place after that tribal roundtable that Michelle just mentioned, and then I think we'll explore what the best method is to when we'll, at that roundtable, what the best method is to determine those numbers.
Okay, so more to come at the roundtable. Any other questions?
I just had a question about, about one of the things that we're really worried about is like the whole idea of the -80 freezers, just because there's not a lot of urban programs that have, those available. And I just wondered, and I'm thinking that that might be true for a lot of, more higher risk populations, that the health centers where people would be vaccinated might not have access or even the funds to be able to purchase something like that. And so I think it would be really helpful, to get some guidance from the state on, where to find those, how much they would cost. Yeah.
Perfect. So our vaccine response plan is due to the CDC actually tomorrow, and so then we'll definitely share that with our with the VAC. In the meantime, I know that a lot of those storage units are on back order, and also the CDC has been sharing that they're not recommending that places purchase those negative 70, negative 80 storage units. And so it seems like the CDC is trying to develop different logistical solutions for instead of buying those large units. For example, units that can be recharged, adding dry ice, stuff. So we try to put as much of that information in our vaccine response plan, and then we'll continue to add to it as we learn more about that vaccine.
The only thing I'll add to that, Shan, is just that we are looking at kind of assessing to figure out where those types of cold storage units may be. We do not think they're super common, but where they may exist in our state and collecting that information. So that when we can think about how do we use places that have those existing locations and what other types of health centers may they be near. And then also, do we need to consider any backup solutions as well? So there's lots to come in this area, but right now, I'll just reiterate what Sheann said, is that CDC is working on a packaging solution that will hold temperature for a week, and CDC is not recommending purchase. The other thing that I want to make sure everybody really understands, and we've gotten some confusion on this, just as different levels of people are involved who may not usually be involved in vaccine distribution. When the state gets an allocation of vaccine, that vaccine does not come to the state. So it will be stored centrally by the federal government, and then we'll get the order against it. So that means that we'll help facilitate, once we know where the providers go, we'll facilitate sending a shipment of vaccine. That's what they can use in the time, ideally, that it will be hopefully be able to be stable in the CDC packaging. And then the providers will be able to order again. So I do just kind of want to alleviate the concern that we're going to need to figure out massive amounts of cold chain storage for all the vaccine we're going to be allocated. It's really more of a real-time shipment of vaccine for the quantity that will be needed probably over the next week. So that's some of the types of information we're going to work with healthcare providers, and you'll see when you look at information being shared about how providers can prepare. Is really we want providers to start thinking about what their throughput is, how many patients or staff members or other things do they have in this category. So that's going to help us all as we're making these decisions about allocations, really decide kind of in real time how many doses of vaccine can be used like in the next week to help us make those decisions.
So Michelle, this is Rachel. Just, I think I had heard on one of these presentations that especially the ultra cold may only come in dose numbers of 1,000 doses, which I just am concerned about the logistics of using 1,000 doses. Even if you vaccinated 100 people a day, that would take 10 days.
Yeah.
Any comments on that?
Absolutely, we have the same concern, and that's regular feedback that I believe is going to CDC. But one of the things CDC, just I heard today from them, they are taking it into consideration between depending on what vaccine the candidates are where and how they made and how they're allocated appropriately. So maybe if vaccines are available about the same time, the 1,000 dose allocation could go for urban areas. I think there's actually probably very few areas, even in our state, where we could use 1,000 doses at once, besides probably a lot of places in the Puget Sound or maybe only in King County. So that's something that we're going to be looking at closely. I think there is a lot of concern about making sure we're not creating any inequities between rural areas and more urban areas. I also think one of the things we're waiting for more formal guidance on too is CDC about redistribution and packing using the materials they have, so that if there's two hospitals in a more rural area that maybe are, a couple hours apart, is there a way we'll be able to split out that 1,000 dose order? Or if we have pharmacies or other providers who maybe have the right storage and equipment in an area. So those are all the types of solutions we're thinking about. We definitely welcome questions and input on this, because this does create some unique challenges.
Great. I know that Jeff Duchin needs to leave at 12:15. We're very fortunate that he is on the COVID-19 work group for the ACIP. So before he needs to hop off at 12:15, I just wanted to give him an opportunity to give any updates that he may be able to give from the national perspective. And he has, I think, gained a lot of scientific expertise around these different new vaccine platforms. So we may have questions for him as well. So I don't know, Jeff, is there anything that you wanted to share from the national perspective?
Thanks, Jeff. So just in a nutshell, the ACIP COVID-19 vaccine work group is a multidisciplinary subset of ACIP members and liaisons from across the federal government, including FDA, HHS, NIH, and then a large number of stakeholder organizations, medical professional and others, and then some subject matter experts around vaccine safety, immunology, vaccinology, and so on. And the work group meets to develop information to share with the full 12-member ACIP to inform the evidence to recommendation guidelines that ACIP will issue once FDA authorizes a product. And that could be either through an EUA, which is what we expect, or the traditional licensure pathway. So this work group has been meeting weekly for quite a while now and reviewing the various vaccines that are both in development and in early phase clinical trials, as well as the 4 vaccines that are in phase 3 clinical trials here in the US. Looking at the whatever data the manufacturers can present to us. No efficacy data yet, but primate data, animal data, the early preclinical data, and then some immunogenicity data, as well as issues around prioritization and allocation frameworks that are informed by the National Academy of Medicine recent publication, as well as the Johns Hopkins piece on this, and issues around racial and ethnic disparities in COVID-19, social vulnerability, and developing a proposal for an ethics and equity framework for COVID-19 vaccine allocation. The work group also is putting together, well, actually facilitating a separate activity, an enhanced vaccine safety surveillance activity that will be done by CDC in collaboration with others, a more intensive vaccine surveillance activity than I've seen before, which will involve a variety of different reporting mechanisms. And then, of course, this really important issue for our group here in Washington State around allocation and implementation. So those are the main issues that the work group is dealing with. And, I can't give you any more insight into, when a vaccine might be approved, although as recently as this week, the head of Operation Warp Speed still says he expects that there will be data submitted to FDA before the end of the year. And at that point, FDA will evaluate safety and effectiveness and make a determination about approval. And then when that happens, it will go immediately to the ACIP for recommendations to healthcare providers about how to use the vaccine. So the ACIP cannot produce any recommendations until they see the safety and effectiveness data across different subsets of the population. So when people say they're waiting for ACIP guidance, you have to understand that guidance will not be possible until there's information submitted to FDA that they share with ACIP about the particular vaccine that we're talking about, how it works in different subsets of the population. I would, if you haven't visited the ACIP meeting website, it's a really informative site where you can find the presentation slides from the ACIP meetings and the meeting minutes. So if you want just a quick overview or a reference on what's happening, you can download those materials and have them on hand for yourself. So I'll stop there.
Does anyone have any questions for Jeff?
Jeff, once the safety and efficacy data is submitted to the FDA, how long is the approval process? It's Mary.
Yeah, So FDA will convene a working group that they have, the Vaccine and Related Biological Products Advisory Committee, which people refer to as VRPAC. And that is their expert, a group of experts who will evaluate safety and effectiveness data. So they request the manufacturers submit to FDA within 24 hours of declaring their intention to submit, and then FDA will immediately convene that group. I can't predict how long the deliberations of that group will take. I guess it depends to, what the data look like in front of them and how much more they need to clarify with the manufacturers and how long it will take the manufacturers to provide any additional clarifications. But FDA earlier this month, issued some guidance to industry about the type of data that they want. For example, they're requesting that if an EUA application is made, that it ensures at least 50% effectiveness, which we would like to see higher, but that the FDA will accept 50% effectiveness, and they want to ensure that at least 50% of the enrollees have had 2 months of post second dose monitoring for safety. Now, of course, this is not, the typical duration that you would see if they went through conventional licensure, where the observation periods can be much longer. But because this is a crisis situation, this is a compromise that most people think is reasonable. And then immediately, once the FDA decision is made, it goes to the ACIP. And we've been encouraging FDA to share information with the ACIP even before they make a decision, so the ACIP can start thinking about this in advance and not have to sort of start over again if there's an opportunity to sort of get a head start on looking at the data.
Sure. Okay. Thanks.
Yeah, and just so that everybody's clear, that VRPAC group, the independent group of experts that makes a recommendation to the FDA, does hold a public meeting to deliberate over the data that they're reviewing from the trials. So that is a public, transparent process.
And the other piece I want to say, since Dr. Duchin really explained the clinical trial process and some of the data outcomes that FDA is expecting, or data that they're expecting to see for an EUA application, that does not stop the clinical trials, is what I want to add. They'll be going on, they'll continue on, as will post-licensure safety monitoring. And I'm assuming most of these companies will want to continue to collect the data to meet what the endpoints are expected to apply for full licensure from the FDA. So just wanted to add that in, especially for our public members, to say there will be lots of ongoing clinical trials and safety monitoring.
That's what we desire. That's the recommendation.
Great. Any other questions for Jeff? Oh, the other thing I just wanted to make sure people understand is that the vaccine companies have been manufacturing vaccine while the trials have been going on. And that's why, if there is a vaccine that gets FDA approval and then is recommended by ACIP, they have doses that are going to be immediately available to ship because they have been producing it. They are producing it now. Great. Any other questions? Okay, well, we really appreciate that information, Jeff. Thanks for sharing.
Thanks.
So let's go ahead and continue on. Greg, you want to talk about some of the work going on around communications?
Yes, thank you. So we're working in the Department of Health to actually start beginning to communicate this out to the public. All these wonderful plans are only as good as we get the information out to the public to get ready to get the vaccination. So the way I started out is imagining a big ball of yarn. It's an example I've used a couple of times, but inside that big ball of yarn is a lot of information: people's willingness, distrust for public or national health figures, vaccine hesitancies built in, There's also other frustration, tiredness, all built into that. So we need to unravel this kind of communications and understand what's inside, and then rebuild it back into something and knit it back into something that the public is understanding and ready to then be ready to take the COVID vaccine. But here's some considerations listed on the screen that we're looking at. Our goal is to need a high percentage of the population, obviously, within Washington State to get the vaccination in order to move ourselves along. And so we're going to work as fast as quickly as we can to start beginning the messaging out to the public to get ready for the vaccination, and then move through different phases as we go along. Next slide, please. So our goals, oops, my slides are different because I have my notes on them, is that in the next 12 to 24 months, we're going to have a 5-phase process that will work through educating the public. And the timing will start roughly, we're thinking in the month of November to start beginning the education process and the communication. But phase 1 actually lays the groundwork for a COVID-19 vaccine distribution and begins to get the audience understanding what and how that looks. In phase 2, we'll go into an early audience behavior adoption where they actually start to maybe get the vaccine in that time. And then we'll also keep up the same information around masking, social distance, et cetera, and keep that behavior going on. By phase 3, we're looking at a broader dissemination of information to make sure we get a broader group of audiences adopting the behavior while also keeping the mitigation efforts enhanced. By phase 4, we're thinking that's going to be the mass communication for the large group of dissemination of the information. Then last but not least, phase 5, which again, we're at the 24-month phase, about 2 years, getting to the point of grabbing people that may have not adopted the vaccine and how to help them get and move toward that information. And then next slide. Our goal again is to reach about 80% of 18 plus audience, that's where the studies are currently going right now. We are doing a heavy push by the end of this year. So by the end of December 31st, we're going to start some informational campaign. We're going to use both social marketing, health promotion, and social science. We're going to use the best practices we know from vaccine promotion. And we're also going to partner together with health equity and social justice to make sure that we're reaching all audiences in the way they need to be communicated with to best get the information that they need. We're going to do a large ad buy that lays the groundwork for the COVID-19 vaccine dissemination. And the goal of this ad buy is to build trust and credibility with key audiences, and to understand the willingness to vaccinate and to identify key concerns during this process. You'll hear more about that when Katie Meehan speaks, but inside there, along with other avenues, we're actually working intently on trying to get that deeper level of understanding of informational needs and find out where hesitancy exists so we can address those directly and help bring people along with us as we're moving toward that. And then third is develop a system of partner engagement, which again, Katie will speak about too, and others, to make sure that we have that information going out across all areas and groups, across the whole age and lifespan as we continue to push the information out. Next slide. So the overall understanding goal of this audience research that we're going to start, that was actually beginning October 27th, is to understand barriers, beliefs, and motivators for each audience around the COVID vaccine, and divide key messengers within each audience, channels and styles of how each person would like to be communicated with. We are going to be doing it across multiple audiences in 11 different language segments, ranging from ASL, Russian, Ukrainian, Vietnamese, Chinese, Arabic, Punjabi, Somali, Korean, and Tagalog. I apologize if I said it wrong. We're also going to go across rural, college students, African American and Black community, adults 25 plus, Spanish speakers, Hispanic, Latinx, Asian Pacific Islander, Native Hawaiian, LGBTQ, and the pro-vaccine advocates, to really go across all those different audiences to get a good understanding of where things are at. Addresses, the three areas we're looking to address is explain how vaccines are made, tested, proven safe and effective, even during warp speed. Explain how vaccines work in the body. And then third, provide Washingtonians with skills to navigate misinformation and seek credible sources of information. So those are our first three large pushes that we're going to do. We're going to do it in a mixed methodology. We're going to actually work on doing both quantitative and qualitative research with these audiences and doing key informant interviews and in online discussion panels, again, in the language that is appropriate for the audience. As we develop materials and begin to push items out the door, whether it be commercials, radio, digital media, et cetera, we're going to use a 4-pillar group of a tightly knit group of people to bounce ideas off. And some of that maybe involves some of you if you're interested. That the 4 pillars would be communications, equity, epidemiology, and then subject matter expertise. Those 4 areas would then be a rapid review team to look at things we've created with our ad company, to balance it out, get key reactions, look for any major red flags, also to make sure that we're communicating in the right way, because again, we're so tight to the work, we want everyone's opinion around it, and then move it forward from there. So we may have an ask that comes out, and if you're we'd love to have you participate. And next slide. Again, this is the messaging that will go out in November. Is again, how are they made, how they work in the body, guidance for seeking credible information and learn more, driving people to our website. We're at the website, it'll be translated into many different languages, more than just the ones I listed, to make sure people have the resource available in the language that they need with the key and credible information at hand. So that's a quick overview. Really, I had 5 minutes, so I tried my best to cram it all into 5 minutes there. But the next slide is, what questions do you have, thoughts, concerns, etc. And last but not least, I forgot to add, we are partnering with the Gates Foundation starting in November. There is interview questions that are done on a regular basis, sent out throughout the United States to get thoughts and feelings. We're adding specific questions with the Gates Foundations around vaccines, vaccine hesitancy, thoughts and feelings around that. So that partnership with the Gates Foundation will continue as we move those questions into their regular ongoing survey. So we'll keep a pulse regularly of what the audiences are thinking, as we believe that the adoption of COVID vaccine will only increase as time goes on, as the first round of people get it, and we believe it will show that they're doing just fine, and we'll keep moving and rolling upward and upward and upward, but keeping in touch with our audiences throughout the whole time.
So Greg, this is Rachel. I was just wondering about, and you probably already have addressed this, promotoras, faith-based guidance, like, priests or rabbis or spiritual leaders, in terms of, and people living in communities where there may be disparities in getting the information that promoted.
So I think I can answer your question. It's around the spiritual community. So in the work that we're doing in partnership with the Community Engagement Task Force, there's a whole deep dive kind of into different pockets of Washington State that will look into these spiritual and religious groups are one of those areas to be looked at. And I'll probably let Katie speak to that more when her portion comes up, but that's a piece to look in and how we understand what they need, and then also figure out what is the best way to communicate with them. And they will help us inform how we do that. So we'll take the information and tailor make items if necessary, based on what we hear, to make sure we get the right information to them to get that out. But it's about finding those trusted leaders within those communities as well that can help us communicate, as we have done in our Ukrainian-Russian work that is about around vaccine hesitancy. It's about finding those people connections that can help us communicate the information.
And Greg, there's also a question in the chat box from Tam, who's asking about, I think, work with American Indians and Alaska Natives. I think it was on the slide where you were talking about audiences. And
I apologize if I did not read them. In my rapidness, we are partnering with the American Indian Alaska Native individuals. The work that we've begun with our enhanced influenza campaign has already laid that groundwork, and we're doing it with urban Indians populations and working with 3 larger groups to help across the whole Native culture across Washington State. So we are doing that partnership. We plan to build upon that and discuss that more at the roundtable on the 27th. But then offering support and incentives to help and tools and materials and whatever they need to make sure they have what they need to also work with the American Indian, Alaska Native populations.
Great, thank you.
I also really like the idea of educating about how vaccines work. I think that's one of our major pitfalls, is that people they don't understand their own immune system. They don't understand how these vaccines work. To them, it's a big vial of chemicals that do hoodoo voodoo. I love the social media post I saw where somebody wished instead of vaccines, they could just get a bit of the virus to learn how to be immune to it. So I also wonder if there's an opportunity to make optional curriculum available for schools and just make sure this is in our schools and kind of take that initiative, back to recycling and so many other things, seatbelts, where we taught kids and they kind of rubbed off on their parents. I wonder if this is a great opportunity to kind of make available something easily digested, a YouTube or something that kind of is different age appropriate that teachers might be able to work into their curriculum.
And I love that idea, and Ed Marquez has brought that up at Vax Northwest as well, working with a group out of Canada that has that same idea, but just helping kids infuse those basics of bringing that in. But yes, that's a great idea, and we can add that too. We have OSPI obviously as a partner. Working things into curriculum is much more challenging these days, as with anything, because they have such tight windows of how to get things inserted, and it's such a political process of getting curriculum changed. But we can definitely work with our partners to see if there's an opportunity there.
I just to be clear, and this is just so that people understand kind of the fundamentals of how vaccines work in an easy digested way, not trying to, require anything. And so I'm actually not so much on the requiring the curriculum and the curriculum change. It's more making it available so that as teachers, health programs are teaching about immunology in high school, they can use that, or if it fits into kind of a science lesson that a teacher's doing in elementary school, that if they're interested, they could adopt that. And probably something exists, and we just need to identify it and make it available to the schools to share.
Yeah, we have a lot of undoing to do around messaging. There's a lot of false information floating around right now, and there's a lot of things being shared, and some of the smartest people I know are reciting some of the false information. So it's really about undoing that and getting back to science and understanding the basics of how your body works.
I had a patient yesterday who didn't want to get a flu vaccine because the mom, I think the way she worded it was concerned I might sprinkle a COVID vaccine into it and like sneakily give them a COVID vaccine. So I just been hearing a lot of those kinds of concerns, like Kathy had mentioned in the very beginning about the public comments about them being mandated and just things that just aren't happening. That really base level education, I think, is really, really important. There's like the inherent distrust is through the roof right now, much more so than at its base level.
And as much as this is the campaign, we're going to move into developing materials also that will be available in a toolkit in future versions once we know what the candidates are and how this is going to be deployed to make it easier and attainable for provider offices. So we'll have things available that hopefully be visually easy and simple to communicate with. So we'll have lots of different opportunities to make things available so that you won't have to create things yourselves.
One potential tool that we're using in the school-based clinics is, I'm actually doing this and working on it later today, is we're making videos for the teachers to show in the advisory class with various types of health messaging. And they're just like 1 or 2 minute videos about how to properly mask, that it needs to go over your nose, or how to wash your hands properly. Like these really kind of base level education. And I don't know how that would work with a vaccine, but it might be a potential venue to get some information out.
Mm-hmm. Great, Susan?
Yes, I'm in Chelan Douglas County. I've heard that 80% of the COVID disease is currently in the Hispanic population. And that's been a difficult population to reach. I was talking to the local health officer who said that there's one radio station in Spanish in Bridgeport that broadcasts just for 3 hours on Sunday. So there's difficulty accessing, getting that information out to this population who has a large part of that disease in our 2 counties here. So I think that's something we're going to need to work on, is how do we reach that population.
Thank you for that. And that work has begun is beginning in the community engagement task force that we set up through the COVID response. Katie Meehan can obviously, her group actually has individual based contracts with different pocket groups throughout the state of Washington that get to the ground. We're trying to get to the closest to the ground as possible to get into those communities to share that information. Some of it may be through radio, some it may through word of mouth, some of it may be as simple as getting people to go door to door and help share that information. So really trying to get down to the ground level to communicate into those pockets that you're speaking about.
Okay, I'm going to move us along just so that we can get through everything. I think, is Kathy Bay on the phone? I think Kathy Bay is going to talk a little bit about our Vaccine Science Advisory Work Group.
I am on the phone. Thank you, Kathy. I really have 5 minutes also, and I'm going to stick to that because although we have, we're doing a lot of work with prep work and planning, the group has only met once. So I wanted to let you know that we are continuing to look at the charter for the group and have looked at the goals and the scope for the group as a kind of a work group on the Vaccine Advisory Committee. I do appreciate, we actually have several members from VAC who volunteered to be members of we're calling it the VAC Solve group as a work group for the process. And then we do have a large group of a group of people from outside of VAC also to bring additional perspectives, either by specialty areas or just literally thinking about the, kind of the sociology or the mental health component of, the vaccine science. So you see the goal and the scope there. We actually, you can't see, I can see. So the goal really to continue to look at the planning and the policy through participation of vaccine experts, both biomedical and social sciences, to think about the SARS-CoV-2 vaccine. And then the scope, again, we're continuing to morph that scope a little bit as we think about the work that can be done by this group and the time commitment that we're asking of people, but really wanting to make sure that we're thinking both from a clinical practicing and a scientific standpoint, what are we doing to think about, ensuring the processes that need to happen for information purposes. So, so those are 2 pieces. A second piece is, again, the membership includes members of VAC, and then also people with experience in vaccine science. And we do have a medical anthropologist who has experience looking at vaccine hesitancy, who's a member of our group. We have a lot of faculty or associate faculty, adjunct faculty from different, particularly UW in the group, which makes sense given not only the breadth and respect for UW, but also given our location. So we are meeting again tomorrow, and we're on kind of an every other week rotation. And last week we actually looked at the allocation framework, which you're going to hear more about in just a moment. Excuse me, to talk about equitable allocation of COVID-19, and given the idea that we won't have, as has already been discussed, we won't have a full complement of vaccine when we start, that not everybody who wants it potentially could get it, but we're also balancing the other side with the idea that we may have more vaccine than there is demand for, depending on, how things go forward. There are a couple of folks, actually 4 or 5 from VAC that are members. I just want to say thank you again to everybody who, either volunteered or said, gosh, I think this person will be a great person for the group. I don't know if there's anything, I think I have like 1 minute left. If there's anybody from the work group who would like to add anything to the message. Okay, I'm going to turn over to, I think Katie is behind me. Is that correct? Nope, it's Blair. Okay. All right, Blair, it's all yours.
Great. Good afternoon, everybody. Can you hear me okay? Good. All right. So I'm going to talk a little bit about what our thinking is regarding prioritization and allocation. As everybody has said, you know, in an ideal world, we would have enough vaccine from the start. We wouldn't have to think about this, but that's just not the situation that we're anticipating. At the same time, ideally, we would have federal guidance about how to approach prioritization and allocation, but we're going to have to kind of develop our own sort of working framework and then try to adapt it over time. So what I'm going to walk you through is what's that working framework that we're starting with. Katie, following me, will talk about how we're consulting with external community partners to gather feedback on it. But I'm just going to walk you through the framework and love to get your guidance and feedback in terms of, are you comfortable with this approach or any other ideas? Next slide. So this is where we're at. We have developed a draft framework. We're now entering into a phase of consulting with external community partners, continuing to get information from ACIP as it evolves and other sources of guidance. And then our hope, which is to really sort of finalize this working draft in November and then be able to move on from planning. But we're going to anticipate having to update it again and again with more information. In parallel, we're trying to estimate the size of different population groups to help our planning and thinking about the different scenarios of vaccines or different presentations we might have so that that can facilitate the planning as well. And thinking about how do we reach out to these, particularly the early first phase populations most effectively. Next slide. So as I said before, and I'm gonna keep saying it again, so where we start may not be where we end up. So, and that's because we're gonna have to approach this with a sense of adaptation in mind. The process we've been using, which has been relying heavily upon the federal guidelines, we've been looking at input from CDC, from WHO, from the National Academies of Sciences, Engineering, and Medicine, from Hopkins Center Security. We're right now leaning more heavily using this National Academies approach. It's just the most sort of fleshed out and further ahead in terms of thinking through all the elements. But we're also leveraging lessons from experience with PPE, and we're going to use these consultations that Katie will describe further with community partners. All of that we hope to provide as input, and at the same time, the world's changing in terms of lots of unknowns about the vaccines themselves, right? The number and timing of doses, the types, what efficacy we see with different populations, what type of transmission we're continuing to see in the broader community with different populations, what results we get when from different populations in the trials, our own epidemic conditions, et cetera, et cetera. All of this may mean that we're going to have to adapt whatever framework we're starting with. Next slide. So what we did was we looked at these different sources and looked initially at the principles that they're using in terms of what are those underlying principles that are important when you're thinking about allocation and prioritization. We've ended up suggesting using the National Academy approach and principles, but I just wanted to show that it really is very consistent with many of the other principles from the other sources in terms of the different components. So I just wanted to give you a sense that I think overall there's a lot of consistency and resonance between these. Next slide. So the principles that we're currently talking about focus on 3 ethical principles and 3 procedural principles. The ethical ones are about, let's make sure that as we're approaching this allocation and prioritization framework, we're thinking about maximizing social benefits. That means both health benefits and societal benefits around socioeconomic well-being. Let's use a principle around equal concern. So let's treat everyone as having equal dignity, worth, and value. Nobody's more important than somebody else. A third around mitigation of health inequities. We know COVID has highlighted the great health inequities in our communities, and how do we make sure that we're using an approach that mitigates some of these vulnerabilities due to social or economic or environmental disparities. And on procedural principle side, we're saying let's take an approach that is very fair and unbiased, Let's use an approach that is based on evidence and data and community wisdom. And let's take an approach that also is built in transparency in terms of how we're communicating openly and clearly and accurately. Next slide. The criteria that the National Academies framework is using to think about the allocation and prioritization approach and framework, which are really these four. So think about, as you're thinking about which populations, think about populations who are at risk of acquiring infection. So those who are sort of greater exposure to where COVID-19 is circulating. So think healthcare workers in healthcare settings with confirmed COVID patients. Think about the risk of severe morbidity, mortality. So these are, who are the populations who are at most risk of severe morbidity or mortality due to a potential infection. I think we've seen a lot with people who have comorbidities. Third, around the risk of negative societal impact. So think about populations that if they got ill or affected, that others' lives and livelihood depend upon them and would be imperiled. So example being a lot of essential workers. And then the fourth, around risk of transmitting disease to others. So who are those who have a greatest risk of potentially transmitting to others? Think about somebody who's maybe performing a CPR procedure. So if you take these four criteria and you apply it against different populations, then next slide. What the National Academies has done is put out a framework that says, here's how then we would phase different populations in the community over 4 phases. These are not tiers, these are phases. It's all about phasing in based upon when you have vaccine available. We've also put here what we're starting to hear from CDC and ACIP in terms of guidance, just so you can compare them and see the similarities, but those are works in progress. So I'm not gonna walk through each of these, I'll let y'all do that on your own, but just you'll see there's a sort of smaller subset of higher risk groups in the phase 1. It becomes a much larger population base inside in phase 2, and then the additional populations in phase 3 and phase 4. And calling out that this equity issue is hugely reinforced as a cross-cutting consideration. So in each of these groups, making sure that we're really thinking about prioritizing populations, geographic areas based upon social vulnerable index or some other type of indice. So this, oh, sorry, go back one more. So this is the framework right now that you'll hear from Katie that we're bringing out to external communities and trying to get feedback in terms of how does this resonate with people, what are their reactions, et cetera. What I want to flag to you all, which is even in this phase 1, we're having to start to think in a much more refined guidance approach. And the reason is, next slide. When we have supply projections from the CDC for the United States, which is on the left side, we've tried to translate that into possible scenarios for Washington State. And our estimates are suggesting that within 2 months, we may be able to vaccinate 150,000 to 450,000 people, depending upon how many vaccines we get and what stage in that range. If you actually look at phase 1, that population size exceeds 3 million people. And so we can't vaccinate everybody in phase 1 with the first 2 months of supplies that we're projecting. And therefore we're having to start to think about how do we provide refined guidance around who are highest risk healthcare workers, what are the highest risk people with comorbidities, et cetera. So that's the guidance that we're starting to develop right now. And hopefully we'll come back and get your feedback on that at another time when we have more time. But just wanted to flag that. Ideally, that only exists for a certain amount of months, and then we'll move into a phase where we have a much larger supply and we can move into a more of a sort of a broader vaccination approach. And with that, I'll pass it over to Katie, who will walk through how we're consulting with external partners on this framework.
Katie, if you're talking, we can't hear you.
know she's online.
Yeah, and Phil and Hannah, could you guys verify that Katie Meehan is unmuted? I'm not seeing her on the list.
Yeah, it doesn't look like she's been made a panelist.
So this is Phil. We didn't have any more space to assign her as a presenter, but she was on here earlier and I did have her unmuted. I'm not seeing her anymore though.
Craig or Sheehan, are you comfortable starting with her slides at a high level?
She's on. It says not unmuted. I'm texting with her.
Okay, perfect.
So while we're waiting and troubleshooting, any initial thoughts from the group around this National Academy of Medicine prioritization framework that they've set up? I mean, that's what we're really using for planning purposes. This, just as a reminder, this is a federal vaccine program and providers are going to be signing agreements to participate in the program. But it does sound like we will, so the federal government will likely, set the prioritization scheme, but from what I'm hearing, we may at the state level have some flexibility, and we're not really sure what that will look like yet. But just wondering if anybody has any comments about the prioritization framework that the National Academies of Medicine has developed. Go ahead, Ed. We can't hear you. It looks like you're trying to talk, though.
Maybe that may be better.
Yeah,
Thank you.
we gotcha.
My concern really is not with one scheme versus another. I think they all have strengths and problems. My biggest concern is adherence to any scheme and adherence so that there's a uniform approach across the state. And some of you may remember back the last time the flu vaccine, when they were in short supply, we got into difficulty with different areas of the state following different policies. And so that's my biggest concern is consistency. And how to do we figure that out.
Yeah, thanks for that comment. And, I remember from the H1N1 vaccine distribution is the other issue we had is we had sort of a framework and an approach, but what happened is that in counties got distribution, but some counties made it through their prioritization list much sooner than others. So they were down vaccinating people who were like the 4th priority, while other counties were still trying to get through the folks that were like the 1st priority. And that caused a lot of chaos. And then people started traveling from like one county to another county because they were on their group. And so I think that's a lesson learned that we need to think about as well. We're trying to get really good estimates of like the number of people in these groups that are in different counties. I think one of the big unknowns is that we don't know what the uptake will be. I mean, we'll be offering vaccine to people. We don't know, how many people will be interested in getting vaccinated. So that makes it a lot harder as well. And if there's more uptake in one part of the state versus another, they may go through their vaccine faster. There are lots of different variables to kind of think about.
I'll also add that we feel like many of us who work for different states, kind of representing professionals across the state, you couldn't give recommendations out for who to vaccinate. You couldn't express that because you had to come up with 35 different versions during H1N1. So it was really hard to support healthcare professionals with that variety of recommendations too.
Right. Do we have Katie yet?
We're still working on it, I think.
Okay.
Still Katie.
Okay. Any other comments about the allocation process?
This is Blair. I was just going to comment on the last issue raised by Ed. we have heard this in some of our initial consultations as well from a number of people, and welcome people's suggestions in terms of how to manage this most effectively. I think Kathy's point of will definitely be depending upon folks giving us good estimates in terms of people who qualify for the kind of conditions and criteria that we're providing. And I think when we come back to you all, we're going to need your help to make sure are we providing clear enough conditions and criteria to actually get those estimates most effectively, both for helping sort of estimating the size, also to think about what's implementable, right? You don't want to come up with guidance that people don't actually aren't able to implement and sort of decide who to give it. And so I think there's a challenge here. I think some other ideas that we've been discussing and welcome feedback, which is can you use sort of a pre-booking approach, and so you could actually identify people and have them pre-book for a vaccination, and then you'd be able to sort of manage moving through phases based upon what people are qualified for. So just to say, we're very open to hearing ideas and suggestions that people have in terms of how to manage this moving forward, because I think it's a shared concern.
This is Rachel. With H1N1, I also remember trying to do a clinic specifically for EMS providers, and then family members came with them and wanted to be vaccinated since they were there already.
Mm-hmm. Yeah, the other question, oh, go ahead, Ed.
That's the other issue that concerns me, which is household contacts with high risk, and how depending on how you define that, you can run through your vaccine very quickly.
Yeah, another question I have for this group that we brought up the other day is, you know, if we get an initial shipment and maybe it covers the first dose of vaccine for all the folks in, say, in phase 1A, when we get our second dose, the other thing we're starting to talk about is, well, should we offer that as the second dose of those individuals that got the first dose, or should we move on to the next group?
Doesn't it depend on efficacy with the first, you know, what's the range of efficacy in terms of protection with the first?
Yeah, but in the trials, I think they're only giving 2 doses and then looking at the vaccine efficacy after the 2 doses, 28 days apart or about a month apart. And so I don't think we're going to have very much data on the efficacy of a single dose.
My hope would be that that's something that Jeff and ACIP and company will give really clear guidance on, because that's one where to bounce off Ed's point writ large, it would be nice if everybody's moving on lockstep all over the country on however we approach that.
I thought I had heard that the first dose wouldn't convey immunity, at least with some of the formulations, and that you'd require the second dose to have immunity. But I can't remember for the life of me where I heard that, so I'll go do some digging. To me, it feels kind of silly to sit on a couple 100,000 doses for a month waiting to revaccinate folks, knowing that we'll get more coming in. So I tend to support a strategy where we vaccinate the first round, and then as more comes in, we vaccinate the second. I know there's risk in that, but to me, that tends to be an approach that I favor myself.
Mm-hmm.
Yeah, and Jenny, just to build upon that, I mean, and I think this is what we're trying to do scenarios around in terms of saying, you know, let's just take those first 2 months. If you get 200,000, you're not going to get it all in the first day. You're going to get it over weeks, right? And so trying to really think through, you know, who are you focusing on for those first couple of weeks? As you're getting more supply, hopefully we'll also be having greater indication of what the supply projections are and sort of lead times of manufacturers, and therefore we can start hopefully real time, unfortunately, but real time have to make some of these decisions in terms of, do you finish where you started? Can you start adding on more based upon actual projections around size of populations and what kind of uptake we're seeing in different population groups, and how well are we meeting some of the geographic kind of diversity that we want to achieve, and et cetera. And so and demographic diversity, right? So I think this is where having information about what actual uptake is going to be super important, as well as projections around supply. And I think we're going to have to make some of those decisions real time versus being able to predict it today.
You know,
Can I ask a question about?
And Kathy, just so you are aware, Katie's unmuted now.
Oh, okay. Amy, did you have a quick question?
Yeah, I just wondered, will uptake be monitored using IIS?
I don't know if Shion, do you want to respond to that? Or Michelle?
Yeah, I can respond, and we can come back at our next meeting and talk a lot more about data monitoring. But yes, largely the IIS will be the primary, and we're working on kind of backup solutions in case we encounter any problems. We are looking at additional technology tools to use with the IIS as well to hopefully make data collection, maybe as data collection options for clinics or others to consider using. So a lot more to come on that.
And John, did you have a quick comment?
Yeah, my only comment to Katie and Jeff is in the interest of making sure, and you guys alluded to this, but really to emphasize, part of making sure that everybody is on board with getting vaccinated is going to be confidence in not merely in the vaccine itself and an understanding of the prioritization, but really confidence in the way in which people are prioritized, because I think that this is going to be a real hot button issue. So all the criteria that went in or that are going into developing this phasing approach, the proposed principles of proposed criteria, to the extent that your communications can allude to those, make those available so that everybody understands the why. I think that'll give them more confidence in the process, and we'll kind of head off some of those problems early on.
Great, thanks, John. Okay, Katie, you're on. I think you only have about 5 minutes, but we can, I think we're gonna have to come back to this topic in another meeting. So we might, if you can maybe start us off and cover what you can in 5 minutes.
Yes, thank you. Can I just get a thumbs up so folks can hear me?
We can hear you.
Perfect, thanks. I'll go quickly. So why don't we go to the next slide? So I want to start with just a timeline and kind of echoing what John just mentioned. Confidence and increasing confidence is really important to all of this. And I want to just acknowledge, through the engagement work, and I'll share a little bit about what we have planned and what's underway. So there's that kind of end product, if you will, of what we're hoping to learn from communities so that we can take what we learn, have it inform our approach and our decisions where we can. But the process is actually just as important as the product. And so we are really trying to take an approach and a process toward our engagement work in a way that at the same time starts to build confidence and also, acknowledge that we don't always have the best standing relationships with a lot of the communities that have been most disproportionately impacted by COVID. And so using this engagement work as an opportunity to help rebuild and repair some of those relationships along the way, really honor and value the time and the commitment that communities and partners are taking and spending with us to give us their feedback, much of which is, feedback that we've heard many times over the many years, because COVID is just unfortunately the most recent example that's shining a light on a lot of the inequities that we already knew existed, right? It's exasperating what communities were already experiencing across our state, and which, exasperating the inequities they've already brought to our attention. So really using this as an opportunity to bring people in, to really listen, to respond to what we hear, and build something and build a decision-making and allocation and prioritization framework that centers folks that are most disproportionately impacted. One of the other things that we're working toward building as part of this process is what does engagement look like past this fall? And so this is the first wave, but we really want to make sure that this isn't a one-time conversation, but we're building something that's going to be sustainable, that's community informed, that has representation, and those trusted messengers, as Greg was talking about earlier, that are going to be really critical for building trust and getting messages and information that's credible, culturally and linguistically appropriate out to communities at every stage that we have. Next slide. I'll skip over this because I talked about it. Next slide. This is a high-level overview of our engagement approach. We are really focusing heavily on communities, again, that are disproportionately impacted by COVID, high-risk workers, both in terms of healthcare and also essential worker categories. This isn't an exhaustive list, but just some examples. And those are more on the individual. Like I'm an individual Washingtonian, and this is my increased risk because of my because of the inequities I've faced throughout my life, because of access barriers, because of my job and the exposure that gives me. And then we also obviously have our partners that we need to be successful in all of our vaccination efforts. So our healthcare and public healthcare partners, our governmental partners, tribes, which were, as Michelle talked about earlier, which we formally going through our formal consultation collaboration procedure for. I also want to mention though that although it looks like these are silos, they aren't, right? We know that there are folks that cross multiple areas here. There's a lot of intersectionality, and it's actually at those intersections where we have folks that are at the greatest risk. And so we really are trying to drill down and hear from people at that place. Just this week, we've had focus groups, for example, with college students, but not just any college students. We've really focused on college students of color who also have parents that are essential workers. And so drilling down at those intersections. We had a focus group with farm workers. There's one planned for a Latinx women's group. This morning, I facilitated a group with parents of special health care needs. Parents of children with special health care needs, youth. We have things planned for the LGBTQ community. And then we have, as Greg mentioned, all of these relationships with community organizations that we've invested in throughout the response, who are also taking our focus group and our question sets and key informant interviews and carrying those out to their own communities. So for example, Austin Health Initiative, this weekend we'll be facilitating a focus group with their community and doing it in 3 languages at the same time to bring in a lot of perspectives that we just aren't well positioned to unfortunately get all the time. Next slide, I realize I have 1 minute, so I'm gonna go quick. I think they will be in there, but I just wanna highlight, we're looking at the NAM framework from a starting place, but we're really trying to look at wherever we are going to have opportunities for decision making around prioritization, allocation, that we're doing that with an equity lens. So for us, that means we're looking at access barriers, we're looking at, who has the higher risk for severe illness, who has higher risk for exposure, who's at high risk for spreading COVID-19 to a high risk population. Next slide.
If you're not talking, can you please put this on that? We're hearing a lot of feedback.
Next slide, please. Next slide, please. Yeah, that's okay. So there's a number of just factors there that we're holding, and we're also hearing back from communities and partners. What else are we missing from those previous lists? This is a high-level overview of our approach. We have a lot of focused engagement work. I gave you some examples of what that is looking like. And then we have some broad engagement efforts as well, knowing that there's a lot of folks we won't be able to have as in-depth conversations with, and providing options for kind of a general public feedback opportunity to capture some of that feedback. So I will go ahead and wrap up there for the sake of time, but I hope we'll have an opportunity to dive in deeper another time and share some of the things that we're hearing through this engagement work. And thank you for letting me come today and present for a little bit.
Great, and sorry about those technical issues. I guess in our last 2 minutes, first of all, anybody have any quick feedback for Katie? Any initial reactions to this community engagement work and how we are trying to get as much feedback as we can around, potential future COVID vaccine program? Ed, are you talking? I think you're on mute if you are.
Thank you. It's going to be very important to make clear that just because vaccine comes into the state, masking and social distancing needs to be continued. And I'm afraid that it's clear that will be a challenging message, but it's got to be there from the get-go.
Yeah, thanks. We have talked about that, and we have tried to start to message some of that. We meet with we have press briefings weekly, and just kind of trying to foreshadow that, you know, once the vaccine's here, that doesn't mean we get to immediately stop all these other activities. Great. All right. Well, we are right at 1 o'clock, and I want to be respectful of all of your time. As you can see, there is a lot packed into this COVID-19 vaccine issue. Lots of different moving parts, lots of different aspects for us to be considering at the Department of Health. And so one thing that we were thinking of is that we were thinking about having an additional VAC meeting in November, just because there's all these moving parts, and we just felt like we needed to sort of bring everybody on the committee up to some basic knowledge about, you know, how we're thinking about, you know, a vaccine program. So watch your calendars. We hope that we can find a time in November that works for most people's calendars. I realize this is an additional meeting to the ones that you guys have committed to, but would appreciate it if you are able to join. Obviously, we would love your input and want as many of you to be able to participate as possible. So watch for that meeting on your calendar. If you have, I know we covered a lot of information today. If you have any thoughts about anything, you know, please feel free to send us emails so that we can start considering ideas that you may have. We're always open to continually receiving input. It doesn't just have to be at the VAC meeting. So feel free to send that in to us. And I guess I'll turn it over to Michelle. Michelle, do you have any other parting comments?
No, just thanks everybody for their time and the great discussion today. Thanks for the members of the public for their comments and to give us additional things to consider. And just everybody stay safe and healthy and mask up. We appreciate all of you.
Great, thanks everybody. Have a good day.
Thank you. Goodbye, everyone.
Bye.
Bye.